everyone. I'm Dr. Katy Johnson. I'm OBGYN at Grand Itasca, started about 6 months ago. And today I'm going to be talking about some pelvic floor concerns that I commonly see in the clinic. It's not an all-inclusive list of pelvic floor disorders, but these are probably the most common ones that I see. So pelvic floor disorders are very common in women, especially with age, and the majority of them can be treated, and a lot of times it can be treated just through the clinic. The most common ones that I see are uterine and bladder prolapse, and then urinary incontinence, and those are the two that I'm going to focus on today. So I'll go over the risk factors for each, both pelvic organ prolapse and urinary incontinence, and then also what treatment options are available for each disorder. So what is prolapse? Prolapse is the descent of either the uterus and vagina into the vaginal opening, and commonly the organs behind it just fall in with it, so things like the bladder or the rectum. It's very common. If I were to just do annual exams on ladies, about 40 to 50% of all women would actually have evidence of prolapse on exam, especially if they've had babies before, but only 3 to 6% of women are symptomatic from it, and that's the ones that I usually see in my clinic. So I have a little bit of anatomy. This is like looking at a woman from the side. So this is normal pelvic anatomy where the uterus is supported high at the top of the vagina, and the bladder and the rectum are also well supported where they're supposed to be. In this next picture, one of the most common things I see is bladder prolapse, so where the bladder is kind of bulging into the vagina, and you can feel it sometimes even on the outside coming out the vaginal opening. A rectocele, which I see not quite as commonly, is where the rectum is actually what's bulging into the vagina. And then uterus prolapse, where the whole uterus is kind of moved on down into the opening. So instead of being up high at the top of the pelvis, it's moved on down. It doesn't have to be only with the uterus. It can happen after hysterectomy. So this would be normal anatomy where the vagina is nice and well supported. The bladder and the rectum are also well supported. But with prolapse, usually something like the bladder starts falling down, or the top of the vagina kind of inverts itself like a tube sock and starts to fall down. So the most common symptoms that women complain of when they present with prolapse is maybe a sensation of pressure or a bulge sensation coming out of their vagina. Sometimes they'll feel like they're sitting on a ball, or just feel like something's hanging in between their legs when they're walking. It can cause pain with intercourse particularly. And it can also cause difficulty emptying the bladder or the bowels, where women feel like they just can't fully empty. It feels like there's always some urine left behind, or they feel like they need to push the prolapse back inside in order to fully empty their bladder or their bowels. So risk factors for having prolapse: having babies, especially vaginal births, but even just being pregnant and having a baby carried to term is a risk factor, even if you had C-sections. Having many babies, having big babies. See, a lot of these things have to do with babies. Age is a big component for developing prolapse. We are upright creatures, and gravity is not our friend, and with time and just more pressure being put on the uterus and the vagina, it can cause those support structures to start to break down and almost stretch a little bit, and that's what can lead to the uterus or the vagina kind of falling down, so to speak. Weight is a risk factor. For the higher your weight, the more likely you are to develop prolapse. And that's, again, because there's just more pressure on those support structures of the pelvic floor that can increase the risk of those tissues stretching. Menopause is a risk factor. A lot of the tissues that are around the vagina and the uterus are sensitive to estrogen, and as our ovaries stop working, as we transition into menopause and we lose that estrogen, those tissues become, they lose their support. They become more stretchy and not as firm support structures for the uterus and the vagina. And then chronic constipation, and this is one that is especially a risk factor for developing a rectocele, or where the rectum prolapses into the vagina. Just that repetitive bearing down and putting extra pressure causes a bulging of the rectum. Having a previous hysterectomy does not necessarily increase the risk of developing prolapse unless you had prolapse at the time of your hysterectomy and there was not something done at that time to correct it. Or if you did have a procedure done, there's the risk that it could recur in the future, especially if it was done at a young age. So I get a lot of questions. I have women who come in, they say, well, my doctor did my exam and they said that I have prolapse. So I'm here. And it doesn't bother them. And they never knew about it before. And like I said, it's very common. And if I did an exam, it's so common that I don't really even comment on it in my notes unless someone has a problem with it, because it is so common. It's not dangerous. It won't increase the risk of developing any issues down the road, such as cancer or anything like that. And treatment is really based on how much it bothers you. If you feel like you can't go exercise because your prolapse bothers you, well, that's something to be seen for. If you feel like you can't chase your grandchildren around because your prolapse is bothering you, that's when it's a good time to come in. But just because your doctor saw it on exam, that's okay. About half the women out there will have it too. So if you do have bothersome symptoms, especially if you're having trouble emptying your bowels or your bladder, that is an important time to come and see a gynecologist. When you can't fully empty your bladder, that urine that's left behind increases the risk of bladder infections, which become a bigger and bigger problem with age. And if you're not able to empty your bladder because of prolapse, that's a time when we really should address it and treat it to prevent the bladder infections. So when there comes to treating prolapse, there are non-surgical treatment options and surgical treatment options, and I'm going to go over both. For the non-surgical treatment options, treating constipation is really important if you have it. And that can be, just a daily fiber supplement or whatever may be needed to help with keeping things more regular so you don't feel like you have to bear down anymore. Pelvic floor physical therapy is another good option for some women. It doesn't correct the prolapse, it won't put everything back up there, but it helps with the symptoms. It's done by a specially trained physical therapist who can help you isolate the muscles of the pelvic floor and learn how to kind of strengthen those and do exercises on your own so that the bulge symptoms or the pressure are less noticeable. And then a pessary is something that I can offer. So what is a pessary? It is basically a space-filling object that just pushes everything back up inside. It doesn't make the prolapse go away, it just makes the symptoms go away. Usually when I have patients come in, we do a fitting for the pessary right in the clinic. I'll place the pessary, I'll have women bear down to try and push out the pessary. And if that, if it stays in place with that, then I have you walk around the room, do some squats or lunges, do whatever you may need to do to try and get the pessary out, because if it's going to fall out, I want to know about it in the clinic so that we can get the right size, rather than send you home and then say, oh, it fell out right when I got out of the car. And then you have to make another appointment to come back and get a different size. So we try and get you to basically make the pessary fall out in clinic so that we can make sure that we get you fitted for the right size the first time. Most women at their fitting are able to be taught how to remove and reinsert the pessary themselves. And so for those patients, I usually have them wear the pessary during the day and then take the pessary out at night to clean it and give the vagina a break. But sometimes women only have symptoms with certain activities, and so if it's just exercise that bothers you, or if it's a long day on your feet that you start to notice the prolapse, then you only have to wear the pessary at those times if that's when you want to. Or it can be worn all the time. For some women, they have trouble removing or replacing the pessary on their own, whether it be arthritis or flexibility or mobility issues. Sometimes they just have a hard time getting the pessary in and out. For those women, it's okay to wear the pessary all the time. I just have you come back to the clinic every couple months where I take the pessary out I clean it, and then I do an exam to make sure that the vagina is not getting irritated from the pessary. So this is a picture of, there's many, many shapes and sizes of pessaries, but these are the most common sizes and shapes that I use. This one is a ring pessary, and I usually use the one with the membrane, so it's called a ring pessary with a support. And then this is called a Gellhorn pessary, which almost acts like a little kickstand. The pessary is fitted right at the top by the cervix, and it basically kind of sits behind the pubic bone and just pushes everything back up. Most women don't feel the pessary once it's in. It's kind of like, you know, back when you were wearing tampons, you didn't notice that it was in there. The pessary works the same way. The vagina doesn't have the same sensation that your skin does, and so the pessary usually is not noticeable. So it just sits kind of at the top of the vagina and holds everything back up and makes that bulge and pressure symptoms go away. And I have many women that wear pessaries for decades and don't have any issues with them. They are made of usually made of a medical grade silicone, so they're very long lasting. I just refit a lady who had been wearing her pessary for almost 20 years and just needed a different size. And the pessary was in great shape still, because they don't absorb anything. So it is a nice, and it can be a very long-term option. With the pessaries, the reason I usually start with the ring pessary is this is the one that most patients can take in and out themselves. If for some reason a ring pessary is not the right fit for someone and we need to go to this other Gellhorn pessary, that one usually patients cannot take in and out themselves. So that's why I do like to start with the ring pessary. For surgical treatment options, there's many different surgery options, but I'm going to go over the two most common ones. So the one that I do is a vaginal repair, where all the incisions are made in the vagina, and I use stitches to basically re-support the top of the vagina and the bladder and the rectum back using your own tissue. I usually do it with a hysterectomy if there is still a uterus in place, but it can be done even after a hysterectomy if the uterus is gone. One of the big benefits of this procedure is there is no mesh involved. So I'm sure you've heard the commercials about vaginal mesh, and it is vaginal mesh associated with prolapse repairs that all those commercials are about. But I do not use any mesh during this procedure, and it can be done here at Grand Itasca. One of the downsides to the procedure is that tissue's already been stretched before and it's already been weakened before, and we're taking that same tissue to put everything back together. So there is a risk that the prolapse could come back with time, and that risk is about 10 to 30%. The risk is higher if you have it done at a young age, so less than 60 would be considered young to have a prolapse repair, and so just given the expected amount of time that you would still have left in your life, there would be a risk that the prolapse could come back. Now that being said, just because a little bit of prolapse comes back, it doesn't mean you'd necessarily need another surgery again, because it may not be as bothersome as it was the first time. So this is what the surgery looks like. So here is an example of bladder prolapse, and in this picture the incision is made in the vagina, and then there are stitches there to help re-support the bladder. Now in reality, most patients do not have just bladder prolapse or just uterus prolapse. It's usually all the pelvic support structures are weakened for the bladder, the uterus, and the rectum. And so when I do the surgery, I usually have to fix all three. There may be one that's more of a dominant symptom, but usually all three need to be addressed. And by addressing all three, it reduces the risk that you'll have problems with the other parts of prolapse in the future. The other main surgery option is called a sacrocolpopexy. And this is a little bit more invasive type of procedure. It can either be done with a large incision, or what's done much more commonly now is via laparoscopy, where they make small incisions on the abdomen and put a camera inside. And they use mesh to kind of re-support the top of the vagina and tag it all the way up to the tailbone. If you still have a uterus, they usually will do a hysterectomy at the time that the surgery is performed. One of the benefits of this surgery is that it lasts much longer than vaginal repairs and a much lower risk of recurrent prolapse. Really, it's about less than 5% risk of recurrent prolapse when this type of surgery is done. However, it carries the risks of mesh, so there is about a 10% risk of serious mesh complications, with the biggest ones being infection and erosion of the mesh into the vagina. This mesh is different than what you hear about on the commercials because this is done abdominally instead of vaginally. It's a little bit different type of mesh, and this one is much safer than what the commercials are about. This one is not available here at Grand Itasca. In order to have this procedure done, you have to be specially trained in the pelvic floor surgeries. And so when you come into the clinic and we talk about all the options, if this is the one that seems right for you, then we refer you to see a urogynecologist, which is either in the Twin Cities or at Mayo. So this is an example of the surgery. So here there's uterus prolapsing, bladder prolapsing, and a little bit of the rectum prolapsing as well. And this is much more commonly how I see it, where there's kind of a little bit of everything. And in this follow-up picture after the surgery, so the uterus is gone. There's a piece of mesh on the front wall of the vagina and on the back wall of the vagina. And then it's almost like a Y-shaped mesh that gets tagged all the way up to the tailbone to kind of realign everything into normal anatomy. This piece of mesh on the front wall and then on the back wall helps support the bladder and the rectum as well. And that, because the mesh is so much longer lasting, that's why it does have lower risk of recurrent prolapse. All right, so next I'm going to move on to urinary incontinence, which is the other more common complaint that I see. So urinary incontinence is the involuntary leakage of urine. Despite the fact that nobody wants to talk about it, it is very common. About 1/4 of young women, half of middle-aged women, and 3/4 of older women have some degree of incontinence. There are several different types of incontinence, but the 3 most common ones that I see are urge incontinence, aka the gotta go, the stress incontinence, which is the laughing, sneezing leakage, and then mixed incontinence, which is a little bit of both. So urge incontinence is also called overactive bladder, and it's where you have leakage of urine after the urge to void, but you just can't make it in time. So this is I saw the sign for the bathroom and I decided, oh man, I gotta go, and you still can't make it in time. Or you wake up and first thing in the morning and, oh my goodness, I gotta go, and can't quite make it there. There are some lifestyle changes that can really help with urge incontinence symptoms. The biggest thing is for nighttime symptoms, limiting fluids after dinner. I have a lot of patients who get up 2, 3, 4 times a night to go to the bathroom, and that's very disruptive to sleep. But limiting fluids after dinner can be helpful. Avoiding alcohol and caffeine. A lot of people don't drink a lot of, they may not drink coffee anymore, but they drink tea. And they think, okay, tea's got to be better for me, but a lot of tea has caffeine in it. And so they don't realize how much caffeine they're actually getting when they are drinking tea all day, and then can't understand why their urge incontinence is so bad. But the caffeine and alcohol, both of them are not only triggers for urgency, but they also act as diuretics, so they make you make more urine. So not only do you have the urge to go more, but there's actually more in your bladder to go, and can make leakage much worse. There are bladder retraining exercises. This is a little bit longer process, but you basically retrain your bladder to space out how often you go, and how to kind of overcome that urge to go to the bathroom. There are many different medications on the market that can be helpful for most patients. So the bladder medications act by relaxing the muscle of the bladder. So when normally the bladder is in kind of a stretch phase when it's filling, and then when it gets full, it says, okay, I'm full, and it starts to do a little squeeze, and you say, oh, I gotta go to the bathroom, and you go, and it doesn't complete the squeeze until you actually get to the bathroom. You say, okay, now is an appropriate time for me to go. With urge incontinence, what happens is the bladder gets a little bit of urine in there and says, oh, I'm full, even though it's not. And it starts the squeeze, and instead of stopping the squeeze until you say that it's okay to go to the bathroom, it just keeps squeezing. And so what the bladder medications do is they help relax that muscle, help control that urge, so that it allows you to go to a point where your bladder is a normal amount of full and allow you to control when that squeeze is going to happen. But if for some reason you either can't take the medications for side effects, or based on the other medications that you're taking, there is something else that can be done with, it's called bladder Botox injections, and our urologist, Dr. Novak, can actually do these at Grand Itasca. Stress incontinence, I would say that they're probably about 50-50 as far as the types of incontinence that patients present with. So stress incontinence is different than urge incontinence. In stress incontinence, the bladder muscle works like it's supposed to, but it's a support problem, and it's a support of the urethra. The urethra is kind of like a garden hose, and normally when the support structures are strong, it's like stepping on a garden hose on the ground. You step on it and the flow stops. But when those support structures start to break down, it's like stepping on a garden hose on a trampoline. No matter how hard you step on it, it's not going to compress, and that flow is not going to stop. And that's a very different problem with stress incontinence. So when you come to the clinic and say, I leak urine, it's important that we differentiate the two because they're treated very differently. Stress incontinence, a lot like prolapse, needs to be treated at the support level. So again, pelvic floor physical therapy with a specially trained physical therapist. This is where the Kegel exercises come in handy. There are also some continence support pessaries that are shaped a little bit differently that can help add extra support specifically underneath the urethra to help kind of re-support the bottom there so that when you cough or sneeze, that it's nice firm base for the urethra. And then there is a minor surgical procedure that's done as an outpatient called a sling. I'm going to go into that a little bit more detail. So in the sling procedure, what we're trying to do is recreate that support underneath the urethra. So there's a small piece of mesh. Again, this is different than the commercial mesh that you see, but a small piece of mesh is placed underneath the urethra, acting almost like a firm hammock, so that when you cough or sneeze, it almost kinks off the urethra so that you don't leak. It's a same-day procedure that can be done at Grand Itasca. The majority of patients have no trouble urinating afterwards, but every once in a while someone needs a few days. It's pretty rare for someone to have a long-term problem urinating after having a sling done. There are a few things that are very helpful for you to do before you come in for an incontinence visit. One of the things that can be very helpful is keeping a bladder diary for a couple of days. And in that you should include what, when, and how much you drink, when and how much you urinate. Are you going often but only small amounts, or are you going often and large amounts? When you leak, and then noting, was there urge before the leakage, or was it you coughed and then you leaked? And keeping track of all these things can be very helpful. What I will often find is, one, the sneaky caffeine in the tea. The other thing is, we're told we need to drink more water. Everyone needs to drink more water. And we're supposed to have about 60 ounces of water a day. And I'll have patients coming in, I drink a lot of water because my doctor told me to, and they're drinking 100 ounces a day or 150 ounces a day, much more than what they need. So yes, they have to go to the bathroom all the time because their bladder is full all the time. And if we address how much they're drinking, it helps us also address the leakage. And being able to write it down and actually see it is very helpful for patients to look at and be like, I didn't realize that, I was drinking this much, or I didn't realize that I was drinking half a pot of coffee every morning. I just kept pouring the cup while I was reading the paper or while I was doing whatever activity, and before you know it, half a pot is gone. And that can be something that can be very informative for patients to keep track of for themselves. This is an example of a bladder diary. There is a website called urologyhealth.org that actually has printable versions of bladder diaries that It just makes it a little easier to fill out, but really, even if you just kept it written down on a piece of paper and brought it with you to the clinic appointment, that is all very, very helpful. So, in conclusion, prolapse and incontinence are very common in women, and there are many treatment options out there, and we can, after meeting together and going over what your goals are and what your symptoms are, we can usually find the right treatment for you. All right,